السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بكم جميعا. آه، أنا أحمد الشيخ، أستاذ مساعد جراحة العظام، كلية طب جامعة بنها. I'm glad to introduce myself. I'm Ahmed Elsheikh, Assistant Professor of Trauma and Orthopedics by University. I'm here to present the operative technique of fixator-assisted plating of distal femoral deformities. I hope this will be inclusive and putting the highlight on this technique and the tips and tricks during the application of such technique. So to start with, I put here some pictures, but really this is not the exact technique that I will describe because I will use nail and I will explain today the standard technique that has been described in the literature. And these photos are from another technique which has some similarities, but I will just explain the standard technique of fixator-assisted plating of distal femoral deformities. So what are the steps of the fixator-assisted deformities? Why are we going to do this? We prefer to use the exam fixator to correct the deformity acutely in theater, but using internal fixation to fix the fracture. While the fixator is still on, then you remove the fixator and leave the internal fixation, and thus would maintain the correction by the internal fixation and give the patient better rehabilitation and post-operative recovery. So the idea of fixator-assisted plating that we are putting the half pins orthogonal to the anatomic axis of the bone, proximal and distal ends. So you put it orthogonally, and then after doing the osteotomy, the pins should end parallel to each other. Thus, you have a straight segment, then you put the internal fixation, which is either by nail or plate. This is the whole idea of fixator-assisted deformity correction. The major point that you should put these pins out of the path of the intended internal fixation, either a plate or a nail. Simple explanation of this. This is the femur. This is the mechanical axis of the femur. And this is, and we all know that the mechanical lateral distal femoral angle is 87. This is the anatomical axis of the femur, and the angle between them are 7 degrees. When we are doing fixator-assisted deformity correction, we rely on the anatomical axis. So this is the anatomical axis of the femur. We should put pins perpendicular to the anatomical axis in the proximal segment. What about the distal segment? The anatomical lateral distal femoral angle is about 80. So we should make another line which is 10 degrees off the joint line. So I can put the pins in this 10 degrees line, as in this picture, and hopefully when we break the bone, you will find that the whole pins are parallel to each other. But definitely they are not parallel to the joint line. This is the major point, because a lot of people get confused about the wire. Why are we putting a wire parallel to the joint, and why are we taking 10 degrees off? Because there is a difference between the mechanical lateral distal femoral angle and the anatomical lateral distal femoral angle. That's why you take this 10 degrees off, and then your fixator should lie beautifully parallel to each other at the end. However, because we are using a specific fixator that allows some amount of adjustment, this is not a big deal. But as a standard teaching for this technique, this is how it was described. So you put a wire parallel to the joint line, put another wire 10 degrees of this, then you put your half pin parallel to the wire, and then everything should end up beautifully nice at the end. This technique needs fixator that has a swivel clamp, and a swivel clamp is crucial in this fixator, because when you see in the picture, we will put the half pins in the deformed position, and when you do the osteotomy, the clamp should rotate along the bar. If you have a fixator that has only standard clamps, which is 90 degrees to the bar, this is very critical, and it can mess everything up because you don't have the fine tuning that we need, that you can increase the angulation or decrease the angulation. So if you don't have a fixator, it should be any type, any make, any company, but with a swivel clamp, that the clamp can rotate up to 20 degrees in both directions. So this is a very important point. Let's start with the technique. So this is a lady, 18 years old, genovalgum. We could have some lessons here, some comments about the X-ray. So we do a standing long leg film. And to have a good standing long leg film, you should see the hips, the knees, the ankles. The hips should be parallel to the floor. The patella should be facing forward. You could say that the left side is not 100% facing forward, but it's okay. We should take also lateral view to see if there is any knee deformities in terms of bone or in terms of soft tissue. Let's draw some lines. This is the clinical photo of the lady, and this is the mechanical axis. Mechanical axis from the center of the head of the femur to the center of the ankle joint, and we can see clearly that there is mechanical axis deviation to the lateral side, which is genovalgum. Next question, where is the deformity? Then we should draw some lines. The mid diaphyseal line of the femur, the line parallel to the joint line, mid diaphyseal axis of the tibia, the line parallel to the joint line. Then we have two angles, the anatomic lateral distal femoral angle, which is 72 or 73 in this case, and the medial proximal tibial angle, and we all know that anatomical and mechanical both are the same, which is 91. Other leg also, it has an ALDFA of 85 and MPTA of 85 also, and the mechanical axis is a bit of varus. It's in the middle of the medial plateau, but we will leave this for another day. So in this leg, where is the deformity? It's in the distal femur. Next step, let's draw the cora. When we build up a joint, an angle which is 10 degrees off, or which is 80 degrees, ALDFA, we will find that the cora end up just proximal to the patella, and if we put everything aligned and we get a good anatomic lateral distal femoral angle, this will count about 10 degrees of valgus deformity. So this simulation, by the way, this software is freely available. It's called GIMP, G-I-M-P. It's like Photoshop or any other drawing. You just need a program that can draw lines, that can measure angles, cut, rotate, move pieces of photos, and then fuse everything together. You can do this by anything. This is a freely available one. Some people use other programs like Bone Ninja and maybe TraumaCAD, but these are need subscription or need some specification. But GIMP, for example, it's free. So this is my simulation, that this is where I should do the osteotomy, just proximal to the patella. And this is where the mechanical axis will end at the end. And this is the prospective nail that I would use. So we start with a wire which is parallel to the joint line. You should have a lateral view to see if the wire is set or not. It will not make a big difference, but at least from the coronal aspect, the wire is parallel to the joint line. And then you have, and if you have the original kit of like Orthofix LRS Advanced, you will have a clamp that has a wire which is already 10 degrees off the sleeve of the half pin. If you don't have, you should do this freehand. So you will take the half pin, which is 10 degrees off this wire. And here we are. So this half pin is 10 degrees of the joint line. What about the lateral view? This is the most critical step. The lateral view, you should put your pins posterior to the frame, to the path of the nail. In this case, we will put a nail. So all our planning is that we put retrograde nail. So these pins should be posterior to the pins. Some colleagues from the USA, they put these pins anterior to the nail. Whichever the techniques, I think both will work, but you should put in your mind where is the entry of the nail and keep your pins out of the entry, either posterior or anterior. Some people would prefer really to do the entry of the retrograde nail at the beginning and just drill the last few centimeters of the distal femur and put there's some sort of like a dummy nail just in the distal femur. Put your half pins. So then you will make sure that when you put your final nail, it will not hit the half pins. So this is one of the tricks, but you can do it, or you can just make sure that you are putting the nail, you are putting the half pins in the right direction. In this X-ray, I will just highlight, please make sure that you are looking at the dead lateral view of the femur. Otherwise, you will see an awful picture. You will make decisions on the wrong photo. So in this X-ray, you can see here that full overlying of both condyles. You can see good Blumenstadt line. You can see patellofemoral normally. So this is a good lateral view. Then you can proceed. This is the expected picture of the half pins posterior to the path of the nail, and this is the rail of the fixator. Proximally, I use this rod just to make sure that I'm doing the right anatomical axis of the femur, and then you will put two half pins just 90 degrees to the mechanical axis of the femur. You don't need to worry about them because they will be just proximal to the nail. That's why we are going up. If you put the pins in the mid of the femur, you would need to put very short nail. In Liverpool, we used short nails for a while, but we have seen more complications with short nail, with loss of reduction and loss of correction. So we shifted to use long retrograde nails. So the two half pins proximal femur will be just at the subtrochanteric area. So we'll have all the femur to put a longer nail without worrying about anything. So we put the two half pins proximal, two half pins distal. Theoretically, these half pins should line up beautifully and be parallel when we do the osteotomy. How would I do the osteotomy? I use the Bastiani technique, which is multiple drill holes and osteotome. So you use 3.2 or 4.5 drill bit. You should make 3 or 4 passes in different directions. So now you created at least 6 to 8 holes in the tube, and then you start using sharp osteotome to connect the dots and break the cortices. This is the clinical photo. This is how it looks like when you are putting the LRS fixator, and this is the entry of the nail. We can see here that this technique is very minimally invasive. That's one of the biggest advantages. This is how we do the osteotomy. So nice clean osteotomy using the Bastiani technique, multiple drill holes in osteotome. Now this is the time of correction. So you do the correction and hold everything with the fixator using the Allen key, and then do the mechanical axis. You can use the cable of the diathermy, or you can use long rods connected with the sockets and make a very long one. Center of the head femur, center of the ankle, where is the mechanical axis in the knee? We can see here that it's just perfectly in the center. Take care that sometimes you lose some correction when you are applying the internal fixation. So be curious about this point and be particular about it. You might do a little bit overcorrection. So when you lose something, you will still end up with a nice one at the end. So make sure about the correction. The correction that you have in the stage of the X-fix is not 100% the same when you put the plate or the nail. Sometimes something changes when you are fixing. So just take care about this. And then you start the standard. You can see that there is some amount of translation. This point will be already planned in the in your preoperative plan. You will do the translation if you are doing Rule 2 osteotomy, which is a little bit far from the CORA. Otherwise, you will not do any translation. So it's according to your plan. Do the remix. You can see here that the reamer is passing fully nicely without hitting any of the nail or the half pins, which are behind my trajectory. And this is the proximal part. You will just end up before the first half pin. This is how it looks like. I will put the nail. I do the locking screws. Make sure that you do not compress too much. Sometimes we do some like hammering or compression. Make sure that when you are compressing, you are not losing what you have corrected. This is the biggest issue and the major trick of this surgery, that you can lose what you have corrected. Clinically, you might think that they will hit each other, but really it's nice and easy. You can see here that the fixator is a little bit posterior to the trajectory of the nail, or even the distal locking screws, and the jig of the nail is nicely lying on the fixator without need to remove the fixator also. The nails they have different configuration. Some of them really have a different jig or different locking screw jig. So, but this is what I use. It has a lateral one, and every time I make sure that it would not hit the fixator when I do at the end. This is how it looks like from the end, from the top, from the bottom. Locking screws is a very crucial part in this surgery, because we all know that distal femur is a bit capacious. The nail is not 100% fixing the ends. So you should put these screws. There are many beautiful drawings in this technical note where to put the blocking screws, but usually we put the blocking screws medially. This lateral view is real example of why you are doing fixator assisted. You can see here that the perfect lateral view, the perfect lateral alignment. There is no recurvatum, no precurvatum, nothing. It's very accurate reduction or very accurate correction in terms of controlling the fragments. This is how it looks like in the AP view, and these are the blocking screws, mostly from the medial side, just to prevent the nail from losing the correction at this point. So this technique, the whole point that it's accurate. The swivel clamp has the potential to increase the correction or decrease the correction according to the mechanical axis. If you are not happy about the mechanical axis that you saw using the rod, you can increase the correction, decrease the correction, and then fix everything. And this accuracy really just near to the gradual correction that can be used by hexapods or Elizar. The precision is controlled intraoperatively by the surgeon using the fixator prior to the internal fixation. But the internal fixation gives you a good post-operative recovery, because there is no X-fix, you have an accurate correction and good internal fixation. There is learning curve. This is very crucial. The technique looks easy, but it's very tricky. And the problem that you can get stuck and you don't know what to do, and then you end up removing the fixator. The issue here that this is not a hinged osteotomy. It's not like open wedge osteotomy of the tibia or the femur. Here we are doing full osteotomy. You will lose the control of the whole distal femur, and it will end up miserably. So take care about this. If you remove the fixator and make everything freehand, you will end up by recurvatum, whatever. It will be very tricky to control the fragment. That's why I only do full osteotomy when I have full control on the segments, proximal and distal. The surgeon at the end would choose the best technique to apply, which is consistent with the deformity and the available tools. If you don't have the proper tool, if you don't have fixator with a swivel clamp, don't do it. It will be a mess if you lose the control and end up doing this freehand. I hope this everything about the surgery, and happy to have any question on my email or after the ending of the session. Thank you so much.